Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is HIV-TB co-infection, case finding, management and prevention of TB. And the speaker is Dr. Birendra Singh, sir. Dr. Birendra Singh, sir, is currently working as a professor with the Department of Medicine at RIMS, Imphal. He is a SACIP member and nodal officer of Telemedicine Center at RIMS. He has published many papers at the national and international level. We welcome you, sir, for today's session and request you to start the session. So you will have to unmute.
Thank you very much, Madam, for your kind introduction. And a very good afternoon, dear friends. As Madam has said, today's topic is HIV-TB co-infection. And we'll be discussing about case finding, management, and prevention of tuberculosis. Just 1 minute. My slide is not moving.
Yeah, so just click on that slide and then press next.
Yeah, okay. Yeah,
yes.
Okay. Dear friends, this is the roadmap of today's discussion. First, we'll have some introduction on the HIV-TB co-infection, then the general principles of management of HIV-TB co-infected patients, management of active TB in the PLA-HIV, and then adverse effects and drug interactions of anti-TB drugs, then ART regimens in people living with HIV with TB co-infection, and management of child living with HIV infected with tuberculosis. And this is the heading of the topic, today's topic. Of course, TB is the most common opportunistic infection in people living with HIV that everybody knows. And then, of course, as a repetition, we want to underline that people living with HIV are 15 to 21 times, and on the average, 18 times more likely to develop active TB disease than people without HIV. And TB accelerates HIV disease progression, and also HIV paves the way for silicon TB and the mycobacterium. That means TB and the HIV is a bidirectional disease, and they are related to each other. And as per the data in 2019, here, 2019, India accounted for an estimated 71,000 incident TB patients among HIV-infected patients. We'll see that here, when a person is infected with HIV, T lymphocyte means CD4 cells. CD4 cells are slowly deflated, and also helper T cells, So these are depleted, and here mycobacterium tuberculosis, of course, infection, the control or prevention or of the TB in a person is through cell immunity. Here, cell immunity is depressed because of the infection with HIV. So T cells are depleted. So mycobacterium tuberculosis gets into the system and very easily. And on the other hand, when TB is entering the body, as a response of the body, there is an immune response, and inflammatory response against the TB produces inflammatory cytokines in the form of interleukin-1, interleukin-6, tumor necrosis factor alpha, and all. So this in turn increases the viral replication of HIV, and also the receptors on the T cells in the form of CCR5 and CXCR4, they are also increased. So the entry of HIV inside the T cells is increased, and so there's a worsening of immunosuppression because the viremia is increased. So TB HIV decreases helper T cells, so which will increase TB infection, and TB infection on the other hand will increase inflammatory cytokines, and they will increase the viremia. Now, what are the general principles of management of HIV-TB co-infected patients? This is the next discussion here. So we have intensified case finding in the form of ICF using 4 symptom complex, or in short 4S complex, fast tracking, and referral of symptomatic patients for repeat molecular diagnostics. Then prompt and effective treatment of active TB in people living with the HIV in accordance with the national TB elimination guidelines and the early initiation and the continuation of ART in people living with the HIV with TB co-infection, and also co-trimestral preventive therapy or CPT in all HIV people living with the HIV with TB co-infection. That means ICF with 4S, and then of course repeat diagnosis, repeat initiation, and CPT initiation is very important. And here 4 symptoms, detailed elaboration in male in adults and the children are different. In adult, we have the 4S are, and current cough is there, and fever is there, and weight loss, of course, and night choice is part of the fever also. But in children, current cough is in the adult, fever same is in the adult, and but here instead of weight loss, we are we'll have a poor weight gain or reported weight loss. Previously, person baby or son was having this weight, and now it's less than the before, less than the previous weight, at least some percentage. Then lastly, history of contact with the TB case in case of children. Now, if this 4S, this is done when a client enters the ERD center at the center. If 4S is positive, then we call it 4S. They will put a stamp with red color. If it's negative, means they put a green or blue stamp, means signifying 4S is negative. If no, if 4S is no, in that case, then we assess for any contraindication for isoniazid preventive therapy or IPT. If the contraindication is not there, then we start giving IPT. If some contraindications exist, then of course we defer IPT. On the other hand, then if 4S is present, one of the symptoms is present, then we have to investigate for TB and other diseases. So under investigation, we find that it's not supportive of TB. Then of course we have to follow up and then assess and consider isoniazid preventive therapy in such a case where TB is not found, and if there's no contraindication. So if there's no contraindication, then start giving IPT in such a case. Now, other diagnosis, not TB, but some other diagnosis also. Then again, give appropriate treatment, and then of course consider IPT. That means IPT is central in all cases where TB is not there. Now, remaining one is when investigated, we find that the TB is there. Then of course we have to treat TB. Now, here this patient with 4S positive, then they are to undergo nucleic acid amplification test in the form of cartridge-based nucleic acid amplification test or the TrueNet also. So this is a very fast, very rapid test. And if appropriate specimen is available, and based on the site, for example, sputum is there, or some other product, for example, bronchoalveolar levages material, or even gastric levages also. So if materials are available, then we do this thing CBNet or TrueNet test. Now, CBNet or NAT, nucleic acid amplification test is negative or not feasible. For example, in this case, appropriate specimen from the site not available. In such a case, then we have to evaluate for TB using appropriate diagnostic test. For example, maybe X-ray, maybe ultrasound of the abdomen, or FNAC of the lymph node, so on and so forth. And then, of course, if it is negative of nucleic acid amplification test, in that case, we cannot rule out TB when the CBNet is negative, but we have to still observe the patient. So if TB is diagnosed by this test, of course, then start ATT at the ARD center itself. And if TB is not TB is ruled out, then evaluate for an alternative diagnosis. Alternative means other diagnosis. Now, here this child is see nucleic acid amplification test is positive for mycobacterium tuberculosis. Here, then 2 things possibilities there. One is rifampicin sensitive on nucleic acid amplification test. If rifampicin sensitive is there, of course we can start ATT at the ART center itself, then send sample for our first line probe assay. So the line probe assay will be done when we have already started ATT. That this is for isoniazid resistant test is done again. If isoniazid resistant is not detected here, then of course we can continue on our first ART line. And if resistant ionase resistance is detected here, and then again on the other side also, if rifampicin resistance is again detected on nucleic acid amplification test, then we can refer this case to the drug resistant TB center or the RTB center for first line line probe assay, and or second line probe assay, or liquid culture for drug sensitivity test. And then of course when these things are done, then of course ATT can be decided at the drug resistant TB center itself. There are some definitions are here. We'll just go through this one. Microbiological confirmation and then anatomical side of the disease. So the first one here, in the microbiologically confirmed TB means a presumptive TB patient with a biological specimen positive for AAB, acid fast bacillus, or positive for Mycobacterium tuberculosis on culture, or positive for TB through quality assure rapid diagnostic molecular test, for example, nucleic acid amplification test or CBNet or TrueNet. So if we find AAB or positivity on this thing, NAT, then of course this is known as microbiologically confirmed tuberculosis. On the other hand, a presumptive TB, clinically diagnosed TB case. So a presumptive TB patient who is not microbiologically confirmed, but diagnosed with active TB by a clinician based on CS X-ray, histopathology of the lymph node or some other tissue, clinical science with a decision to treat the patient with a full course of anti-TB drugs. So, and then in case of children, this is based on presence of abnormalities consistent with TB on X-ray, radiography, history of exposure to an infectious TB case, evidence of TB infection, for example, the tuberculin sensitivity test, and the clinical findings sensitive of TB in the event of negative or unavailable microbiological test. So this is about clinically diagnosed TB without microbiological confirmed. Then another is pulmonary TB. In the site, of course, in the site, pulmonary TB means any microbiological confirmed or clinically confirmed diagnosed case of TB involving lung parenchyma. So lung parenchyma means pulmonary tuberculosis or tracheobronchial tree. Then what about miliary tuberculosis? Miliary tuberculosis is classified as pulmonary tuberculosis because there are lesions in the lung also. Here, then. In the history of previous treatment, maybe new or previously treated patient, a recurrent case here, then ATB patient, new in case of new one, ATB patient who has never had treatment for TB, or has not taken or has taken TB drugs for less than 1 month. So a patient who is not taken at all, or who has taken the ATT drug but less than 1 month, this is known as a new case. And then second term is previously treated patients, those who have received 1 month or more of ATT from any source in the past. So this is previously treated TB, treated more than 1 month or like that. Okay. Any recurrent case of TB is a TB patient previously declared as a successfully treated in form of cure or treatment completed, and is subsequently found to be microbiologically confirmed TB. So patient already treated or cured or completed everything, but now he has got microbiologically confirmed TB. So this is not a recurrent case. Then treatment after failure. Those patients who have previously been treated for TB and whose treatment failed at the end of their most recent course of treatment. So this is treatment failure. So I will say again, previously treated TB, but treatment failed at the end of their most recent course of treatment. Then treatment after loss of follow-up. ATB patient previously treated for TB for 1 month or more and was declared lost to follow-up in their most recent course of treatment and subsequently. So this is lost to follow-up. Then others condition we have got other previously treated patients are those who have previously been treated for TB but who cannot be classified either into the above classification, either new or previously treated. So these are the others. Then drug resistant TB and drug sensitive TB. So we'll discuss these two things. Drug sensitive one is a simple one, ATB case in which the isolated microbial tuberculosis is susceptible to all the first-line drugs like rifampicin, isoniazid, pyrazinamide, and ethambutol. Okay, so this is a drug sensitive. So we have got 4 drugs in the first line: rifampicin, isoniazid, pyrazinamide, and ethambutol. So RICZ. And drug resistant TB, the definition is drug-resistant TB is a disease where the bacilli is resistant to one or more of the anti-TB drugs. So another is MDR-TB. Multi-drug resistant TB is a subset of drug-resistant TB, wherein the TB bacilli are resistant to at least isoniazid and rifampicin, or without resistance to other first-line drugs. For example, rifampicin and isoniazid, and then of course maybe resistant to paracetamol or ethambutol. This is the definition of MDR-TB. Now, what is the regimen for new and previously treated drug-sensitive TB patients? That means isoniazid and rifampicin sensitive or unknown. In such a case, and then of course we have got this column. Type of TB is, for example, new and previously treated case where rifampicin and isoniazides are sensitive, or of course we don't know the exact status. In this case, we have got intensive phase for 2 months and the continuation phase of 4 months. This 2 means 2 months. So we have got ICE, RJD means isoniazide, rifampicin, and paracetamol, ethambutol. Total is 56 doses. And then of course in the continuation phase we have got 4 months. 4 months here. Total dose is 112 doses here. And now ATT is given provided as a fixed dose FDC under the National Tuberculosis Elimination Program here. Intensive phase. The intensive phase consists of 8 weeks of, that means 56 doses. That means daily doses of isoniazide, rifampicin, paracetamide, and ethambutol given under direct observation at the center itself in daily doses as per weight band. Weight band, of course, we'll discuss in the next phase. The continuation phase consists of again 16 weeks of the drugs, but in this case we don't include paracetamide. We include SRE, isoniazide, rifampicin, and ethambutol. So this is the dose here. So according to weight band, we've got if the weight is 25 to 34 kg weight, then of course we give 2 tablets of the combined pill, means fixed drug. This it consists of 275 milligram. Here, 75 milligram of isoniazide, 150 milligram of rifampicin, 40 milligram of this thing paracetamide, and 275 milligram of ethambutol. And this is 2 drugs, 2 tablets of the fixed drug, of course. And then in the continuation phase, also same thing, 2 tablets. The weight band here, 3. Similarly, we can this thing. If we can remember, is quite okay. But usually, what we do is we take a printout of this weight band and keep under our table. And as the patient comes and take the weight, and then of course accordingly, for example, commonest weight is about 35 to 49 kg weight. This is the commonest weight we encountered in our setting here. So we usually give 3 tablets of the combined drug, and in the continuation as well as in the intensive phase as well as in the continuation phase. And one word is here: if the weight of the patient increases by more than 5 kg and crosses the weight band category during the treatment, then of course the patient should be given the next higher weight band. So this is to be kept in our mind. Then put here, TB patient more than 18 years of age will be given 80 doses as per the adult dose weight bands, of course. But those patients less than 18 years of age will be given 80 doses as per the children weight band. So we'll discuss the what is the weight band for children in the later on in this discussion. Of course, if the weight of the patient increases by more than 5 kg, as we have just mentioned, and crosses the next weight band, then of course patients should be given the next higher weight band fixed drug combination, of course. Now, sometimes we may have difficulty in calculating the weight and the dose requirement. So in that case, loose TB drugs can be used for substitutions in case of adverse drug reactions and drug-drug interactions. And previously, we used to give erythromycin in the intensive phase, but erythromycin is now considered as a second-line drug. And then if we have to give fluconazole with ATD, then of course we have to be a little careful regarding because reaction or toxicity in the liver. So because ATT, including distinct rifampicin and the fluconazole, they will increase the chances of hepatotoxicity. Then what is the follow-up first-line ATT? TB patients should be closely monitored for treatment progress and disease response, of course. At least clinical follow-up should be done every month, of course, at least monthly. Then, this is the preferable one, of course. If not possible, the longer, but it should not be follow-up, so it should be followed very carefully. Then improvement in clinical response, increase in weight, and the control of comorbid conditions should be taken into account. And then symptoms and signs of every drug reaction should be closely followed during the course of treatment. Then what about the laboratory follow-up? Of course, we do this thing, sputum microscopy for the pulmonary tuberculosis. And then, of course, and one more thing is nucleic acid amplification test like CBNet should not be done as a follow-up, not even in the end of the course also, because dead particles, dead microbiome tuberculosis can be again picked up by the CBNet. Then sputum examination is done at the completion of the treatment course. Then let's have a look about the adverse effects and the drug interactions of ATD drugs. Now, isoniazid, the commonest main side effect, adverse effect is peripheral neuropathy. So just to prevent this, of course, we give pyridoxine, vitamin B6 as a prophylaxis also. Then skin rash is another important side effect. Then hepatitis and sleepiness, lethargy. Of course, this may not be very important, but peripheral neuropathy and skin rash and hepatitis, these are important side effects. Rarely, isoniazid may produce convulsion, psychosis, arthralgia, or even anemia also. Then here about rifampicin mostly produces nausea, vomiting, abdominal discomfort, and then again, most important thing is the development of hepatitis in the form of jaundice, nausea, vomiting, and abdominal discomfort, and then generalized cutaneous reactions. And thrombocytopenia, so in form of purpura on the skin, and sometimes we may have a fluoride reaction in the initial stage of initiation of rifampicin. Then rarely rifampicin may produce osteomalacia. Then pseudomembranous colitis, again pseudomembranous duodenal crisis, and acute renal failure. Then of course hemolytic anemia may be observed here. Paracetamol, again, the most important adverse effect is the complaint of pain in the joint, arthralgia, and then hepatitis, gastrointestinal problems, and then cutaneous reactions also, and then sometimes sideroblastic anemia. And for ethambutol, the most important thing is retrobulbar neuritis. So patient complains of this thing, diminution of vision or blurring of vision, and occasionally pain. So for ethambutol, the ocular changes here, and this one. Then sometimes there may be sometimes there may be cutaneous generalized cutaneous reaction and the arthralgia, and then peripheral neuropathy. Green one, remove the green one. Yeah. Yeah. Okay. Put it down up again. Yeah. Okay. Oh yeah. Okay. That's just 1 minute. Just 1 minute. Just one. No. I put some this thing in the computer. No. Okay. Anyway, continuing the adverse effects and the drug interactions, of course, upper abdominal pain, of course, suppose it may be frequent. So, what are the responsible ATD drugs? All oral ATD drugs may be responsible. If there's nausea, vomiting, then again, all ATD drugs may be responsible. Nausea, vomiting with jaundice, and of course, yellow color urine, and these are indication of jaundice. In this case, we may think of rifampicin first, isoniazid, and the paracetamol as well also. And then, of course, we have loose stools maybe there, maybe more than 4 times. Okay, in this case, maybe because of rifampicin or isoniazid, or maybe because of the poor hygiene of the patient. If there's itching and rashes, then we can suspect mainly ethambutol, rifampicin, and azithromycin. And here, severe form of rashes in the form of Stevens-Johnson syndrome or toxic epidermal necrolysis here, mainly by ethambutol, rifampicin, and azithromycin. Patient complaining of tiredness, lethargy, headache, pale look, and palpitation, and then we find that patient is anemic and maybe isoniazid and rifampicin and paracetamol again. Then ear toxicity, ringing in the ear, loss of hearing, dizziness, and loss of balance, and leading to recurrent fall. These are because of the azithromycin and the other aminoglycoside. Of course, this is not given in the first line. Of course, also just for this thing mentioned only. And then if there is a kidney toxicity in the form of swelling of the face, legs, or less or no urine at all, then again here aminoglycoside group mainly azithromycin and the kanamycin and all other aminoglycoside may be responsible. As I have said, these are not given in the first line ATT. Patient complaining of giddiness or feeling of abnormal movement, and then of course again aminoglycoside, azithromycin, and but in the first line isoniazid also. But most commonly, patient may complain of tingling and burning, numbness in the hands and the feet. In this case, again, here isoniazid. If the patient complain of seizure, again here maybe isoniazid, maybe rarely. Again, there's a little elaboration of the drugs again. Rifampicin, gut upset, rash, fever, yellow urine, yellowness in the tear, even in saliva, light sensitivity, and of course liver problems, acute renal failure, rifampicin. Then potential drug reaction interaction is very important for patients receiving rifampicin. These are PIs, protease inhibitors, and then NNTIs, and then antifungal drugs like, and then of course oral contraceptives, even other drugs, methadone and the dapsone. Dapsone is given in the leprosy, but we give it in the distinction conditions where cotramazole is contraindicated or patient is allergic to the this one. CPT is allergic, patient is allergic. In that case, dapsone may be given. In such a case, patient has got maybe interaction. Okay. In such a case, then we do not use rifampicin with protease inhibitors like then or nevirapine. Okay. Then rifampicin is usually used in place of rifampicin, but it may also produce a gut upset, rash, eye inflammation, and then blood cell changes, joint pain. Then of course yellowness in the urine, tear, saliva is in the case of rifampicin. And the drug interaction here also here we have got interaction with PIs, NNRTIs, fluconazole, oral contraceptives, steroids, and methadone is in the case of rifampicin. But one important thing we should take care is we should not advise the patient to wear contact lenses because it may become discolored. And we have to avoid nevirapine in the case of patient receiving rifampicin also. Now, some of the important ATD drugs with the ART. So we'll have 3-4 columns here. First column is ARV drugs. Here we have got NRTIs like zidovudine, tenofovir, lamivudine, and stavudine. And here, can you use with rifampicin? Yes, you can use, but as per the weight band of the patient. Then again, usually we advise rifampicin in place of rifampicin. So if the dose rifampicin is used in the dose is 150 milligram OD, and here there is no interaction. Regarding efavirenz, now we can use rifampicin as per the weight band, and then here, but in this case, the efavirenz dose is 600 milligram daily as usual dose, of course. Then nevirapine, for the nevirapine, and there is a severe form of drug interaction, maybe they are with rifampicin because in the form of hepatitis. So we do not suggest to use nevirapine and rifampicin together. So what about rifampicin? Also again do not use. Then the reason is the high risk of liver toxicity here. Then what about boosted PIs, protease inhibitors used with rifampicin? Again, we have discussed drug interaction is there, so we do not use it. And then for rifampicin, of course, we can use, but the dose is 150 milligram. Rifampicin does not interact with protease inhibitors, and the dose is 150 milligram per day. DTZ, of course, we can use rifampicin as per the weight band, same as before. And then, of course, for about rifabutin, the dose is 50 milligram in adult here. Rifampicin interacts with DTZ in the presence of rifampicin. DTZ's dose must be increased. Otherwise, because of the presence of CYP metabolism and interaction, so the dose of the level of the DTZ is reduced. So just to maintain the therapeutic level or serum level, we have to increase dolutegravir 50 milligram usually given, but now is given BD twice daily. When rifampicin is used in place of rifampicin, then dolutegravir, the dose is 50 milligram as usual. And rifampicin also interacts with dolutegravir in the presence of rifampicin. Now, how to manage drug-induced hepatitis here? When to stop the drugs? We have got transient asymptomatic increase in the serum liver enzymes of SGOT, AGPT, ALT, or AST here in the during the early weeks of treatment, or there may in such a case there is no need to interrupt or change the treatment unless there is a anorexia, malaise, vomiting, or clinically evident jaundice. If the patient complains such things, of course, in that case, we may have to change, we may have to interrupt. Otherwise, for mild seductive things, so we don't have to change it. Then clinical features of concern in such a case may include if there is a protracted vomiting or mental changes or signs of bleeding, signifying a severe form of liver injury, all of which suggest impending acute liver failure and require immediate discontinuation of ATD drugs. And we have to observe, we have to follow up, we have to do LFT and again decide again. Then, if jaundice or any of the clinical features sensitive of acute liver failure develop, all the drugs must be stopped until the jaundice or hepatic symptoms have resolved and the liver enzymes have returned to the baseline. So, till such a time, of course, we have to interrupt ATD drugs. Then other causes of hepatitis must be sought in such a setting also. It's advisable to wait 2 weeks after jaundice has disappeared before starting ATD drugs. And there also, in such a case, separate molecules may be given or the fixed drug doses in a lower dose and gradually escalate. Then some certain conditions, in certain conditions, we have to modify ATD drugs here. So in case of renal impairment, what's the dose of ATD drugs? So let's have some discussion in this case. It depends on the severity of the renal impairment, and this renal impairment is defined by creatinine clearance. We have got the many formulas. One of the most popular one is last one is a Cockroach bottle formula, or we have got many Fs like EPI, KDI, KDs, like so many Fs are there to calculate the creatinine clearance here. So in case of suppose we can consider this thing serum creatinine also before calculating serum creatinine clearance also here. If the serum creatinine is 1.5 to 2 milligram, so mild elevation or mild renal impairment is there. Then if the creatinine is 2 to 3 milligram, then we can call it moderate. And if the creatinine is more than 3 milligram per deciliter, then in this case, impairment it may be taken as a severe one. Then we have to calculate this creatinine clearance by this formula or by the different Fs here. Then we have to consider patient's age in years also, patient's weight in kg also, and then of course for calculating this creatinine clearance, we need to know the serum clearance of the patient, creatinine of the patient here. And the formula here, everybody knows creatinine clearance in case of Cockroach formula is 140 milligram, 140 minus age in years divided by multiplied by the weight of the patient in kg, whole divided by serum creatinine, and into 72. In case of female, the whole result is multiplied by 0.85. And usually we put a chart here also, a chart of the creatinine clearance and how much dose should be given in ATT as well as in the ARB also here. So here adverse drug reaction, we have got two columns here. In this slide, we have got one. First is patient has got hepatotoxicity. Then what should be done? This is advice on reintroduction of the ATT. ATT can be given after the liver enzyme returns to twice the upper limit of normal. If the SUT-ACPT level has returned to about twice previously it has risen to 5 times, 6 times, then of course we have already stopped. Now it is reduced and now it is returned to about 2 times of the upper limit of the normal. In that case, we can consider introduction of the ATT drugs. Then if there's ocular toxicity, patient complains of ocular toxicity, here the main suspect is ethambutol. Of course, once patient has had this thing ocular toxicity, then we don't consider reintroduction of ethambutol. We have to consider some other molecules. Then, of course, if the patient has got immune-mediated nephritis, then in such a case, the suspect is rifampicin. So here, if patient has a documented feature of immune-mediated nephritis, we don't consider rifampicin to be reintroduced again here. And non-serious cutaneous adverse drug reactions or no mucous membrane involvement or less than 10% of the body surface area is involved. That means it's not very serious. In such a case, after holding all the drugs, we introduce the drugs at one at a time. For example, we introduce the molecules separately, rifampicin, isoniazid, or ethambutol or pyrazinamide separately, and see the effect. And serious cutaneous drug reactions, for example, involving the mucous membrane or body surface area more than 10% body surface area. In this case, reintroduction is very dangerous. So introduction is not recommended, and so it applies to all the ATT drugs. Then the patient has got documented immune thrombocytopenia. Platelet count is very low, was very low. Then in such a case, main suspect is rifampicin. And here again, since thrombocytopenia is a serious disease, purpura and bleeding may occur anywhere. So introduction of rifampicin again is not recommended. What about aplastic anemia? Main suspect is isoniazid. So again, aplastic anemia, in case of aplastic anemia, we don't introduce isoniazid. Nephrotoxicity here again, main suspect of drug is amyloid glucoside here, and then we can restart in a lower dose, but reintroduction is not recommended. And then, of course, ototoxicity, again, main suspect is, again, amyloid glucoside like cytomycin and all here. Reintroduction is not recommended. In case of diarrhea, and of course, reintroduction is not is recommended with one drug at a time. Okay, and so once the diarrhea is dissolved, of course, we can introduce the drugs slowly. Okay. Regarding the stepwise increase in the dose of drugs to be introduced, for example, for isoniazid, first day lower dose instead of 300 milligram in the dose, adult dose, we give 50 milligram, and then second day full dose as per the weight band, and then third day and the full dose. Rifampicin again we reintroduce with a smaller dose, 75 milligram, and then 300 milligrams second day, and then of course third day onwards full dose. Likewise, pyrazinamide again we give 250 milligram, then second day 1000, and then of course full dose. Then ethambutol again 100 milligram first day, second day 5 milligram, and the full dose. In such a case, of course, the dose should be the principle is in the lower dose initially, and then slowly build up the dose. Now, the types of treatment, outcome, and definitions of TB treatment here. One is cure, another is treatment cure, treatment completed, and treatment success, so on and so forth. So we'll just have a look at what is cure. Cure means microbiologically confirmed TB case at the beginning of the treatment, who were smear positive or culture positive initially, now is negative or smear negative or culture negative at the end of the completion of the treatment. So patient is termed as cured. And then what is treatment completed? A TB patient who has completed treatment without evidence of failure or clinical deterioration during treatment, but with no record to show that smear or culture results of the biological specimen in the last month of treatment was negative. either because test was not done or because result was not available, or clinically diagnosed patient, pulmonary or extrapulmonary, who has received the full course of treatment with no positive or cultures the test at the end of treatment. That means patient has completed treatment, but the results of the smear test or culture test is not available. So patient has completed those. So in such a case, we don't call cure, but we call them as a treatment completed. Then for about treatment success, ATB patient either cure or treatment completed are accounted in treatment success, but is an indicator, but not an outcome. Treatment success is again, I will just read again: patient either cure or treatment completed. Okay, so we can call them as a treatment success, but it's not the outcome. Now, what about a failure? The failure is a TB patient whose biological specimen is still positive by smear or culture at the end of the treatment course. So is a failure. For example, normally we are giving 2 months of intensive and 4 months of continuation phase. Also at the end or towards the end of the continuation phase, we do smear test or culture test is still positive. So is a failure. Now, what is the failure to respond? A case of pediatric TB who fails to have microbiological conversion to negative status, or fails to respond clinically, or deteriorates after 2 weeks of compliant treatment, they shall be deemed to have failed response, provided alternative diagnosis or reasons for non-responsive condition has been ruled out. So failure to respond. Now, loss to follow-up is very common word in case of ERT setting, but in case of TB also we have got LFU here. Loss to follow-up is a TB patient whose treatment was interrupted continuously for 1 month or more. So, so patient has not returned, or due to some other reason, or transfer, patient has gone somewhere, or patient some compliance is not there, so he has interrupted treatment. So for more than 1 month or more, in this case, the loss to follow up. Now, another term is they are not evaluated. Not evaluated means a TB patient for whom no treatment outcome is assigned. This includes again former transfer also. Then another term is here treatment regimen change. For this ATB patient who is on first-line regimen and has been diagnosed as having drug-resistant TB and switched to drug-resistant TB regimen prior to being declared as failed. So this is the treatment change. Now, what is the, let's have some discussion about ART in people living with HIV with TB co-infection. Then what should be our way forward here? Timing of ART in relation to initiation of TB treatment. So we have got TB, HIV co-infected patient here. ART should be started as soon as possible, within 2 weeks of initiating TB treatment, regardless of CD4 count or among people with HIV, people living with HIV, except when signs and symptoms of meningitis are there. In such a case, we have to delay it. So generally, if the patient does not have signs of TB meningitis, and then of course ART should be started as soon as possible. That means within 2 weeks of starting initiation of the ATT. And what is the ART recommended? Those, of course, appropriate ART regimen will be considered here again here. Then another is people living with HIV with TB meningitis. Then in this case, ART should be delayed for at least 4 weeks and initiated within 8 weeks after treatment of TB meningitis initiated. In such a case, corticosteroids should be considered as an adjuvant for treatment of TB meningitis. So in summary, for non-TBM cases within 2 weeks, and for TBM patients, we delayed ART initiation beyond 4 weeks, but it should be started within 8 weeks of the ATD initiation. We have got what is the recommended ART regimen in case of TB patient, TB infected patients here? Okay, and let's consider this one. In the first column, we have got a patient, ART patient, whose weight is more than 30 kg of weight, and then the regimen is TLD, tenofovir, and 3TC is there, and DTG there, 300 milligram and 300 milligram and 50 milligram given at bedtime. And here if the patient is receiving this regime, then of course in the morning, then we have to give DTG in the next morning. That means we continue to give TLD along with the ATT, means 2 months of SREZ E and 4 months of SRE, but and we have to give an extra 50 milligram of dolutegravir in the morning. Then the patient's weight is more than 30 kg weight. Then in that case, we give, instead of tenofovir, we give abacavir 600 milligram and 300 milligram of lamivudine is there, and 1 tablet of DTG at bedtime. Here again, this is the normal ART regime. Here in such a case also, the DTG means 50 milligram, another extra milligram of another extra tablet of DTG is given in the next morning. We continue ATT as before. Then patients with high serum creatinine level, of course, we have to calculate creatinine clearance here. In this case, we avoid tenofovir, but we prefer to give ABC, means abacavir 600 milligram OD and the lamivudine as per the creatinine clearance. Yes, we have discussed this one. So we have to print out this thing, the level of creatinine clearance, and we can use the recommended dose of lamivudine. So it will be easier for us also. And then, of course, in such a case, we give here ATT as before here, but same thing as DTG is given twice. Same dose is given ART and ATT, and in case of ART, we have to give another extra dose of DTG in the morning. Then what about women with childbearing age? Of course, we have to counsel the pregnant woman whether you want to continue DTG or not, because DTG has got the potential of producing neurological defects. So if the woman considers okay, taking the risk, no problem. And then if the patient wants to discontinue DTG, is a different thing. Here a patient is receiving tenofovir, TLD, tenofovir, lamivudine, and variants. Here, same thing. We have to continue TLE, and ATT as before. But if the variance is contraindicated in case of HIV-2 or previously in an RTI exposure, then tenofovir, lamivudine, and lopinavir in this thing, and the ritonavir, the boosted lopinavir is given. Here again, TTF and 3TC lopinavir boosted by ritonavir is given, and the rifampicin must be replaced with rifampicin because we are giving PI in such a case. Now, patient receiving ZLD, zidovudine or tenofovir or abacavir or plus lamivudine and dolutegravir. In such a case, ART has to be continued here, and dolutegravir 50 milligram is a distant dose is given 12 hours after the first dose during the entire period of ATT treatment. This additional disease should be continued even after 2 weeks of completion of the rifampicin containing ATT, because at that time also there is some effect of the liver and CYP will be there because of rifampicin. So we have to continue DTG, giving the DTG BD additional dose of BD after completion of the ATT. How long? 2 weeks. Patient was getting either zidovudine, lamivudine, tenofovir, and abacavir along with lamivudine and rifampicin. Then there's no change in the ART regimen. Here again, of course, we give ATT same dose because we are not giving dolutegravir. So the same ART regime is continue along with the present ATT. Then patient is on zidovudine or tenofovir or abacavir along with this thing lamivudine and PI. Then in such a case, okay, consider ART changing ART to dolutegravir regimen if the patient has not received or has not failed on dolutegravir. And Same here, NNTI plus the Dulgabi is given, and addition dose of the Dulgabi is given, continue, same as discussed as before, means we are giving ATT continuation intensive phase and same dose, and only problem is the addition of one tablet of Dulgabi and the continuation of the Dulgabi beyond 2 weeks after completion of the ATT. If the same PIs containing regimen has to be continued, then modify ATT drugs. In such a case, rifampicin has to be replaced by rifampicin in a dose of 150 milligram daily in the case of this thing. Then the patient is getting protease inhibitor along with DTG, then continue the same ART. And again, DTG should be again here DTG again given twice instead of once daily, and during the entire period. And then of course here if the patient has received the rifampicin, then we don't have to give DTG beyond the completion of ATG, because we have already replaced rifampicin by rifampicin. Now, this topic is drug-resistant TB in people living with HIV. Some definitions are important for us here. What is monoresistant TB? MRTB here. ATB patient whose biological specimen is resistant to one first-line ATB drugs. So this is a monoresistant. For example, patient is resistant to either isoniazid or rifampicin. Then here again, if it is specifically isoniazid, then we call it isoniazid-resistant TB. ISRTB. IC is isoniazid. It comes from the name isoniazid hydrazide. Okay. So ATB patient whose biological specimen is resistant to isoniazid and susceptible to rifampicin has been confirmed. So in such a case, ISRTB requires treatment other than for this thing, drug-resistant TB. Then another important thing is RRTB. That means rifampicin-resistant TB. This is a case. This is a patient whose biological specimen, for example, sputum or lavage or BAL, is resistant to rifampicin, detected during phenotyping or genotypic methods, with or without resistant to other ATT drugs. Then another is the term is poly-drug resistant. Such a case here, a TB patient whose biological specimen is resistant to more than one first-line ATT drugs. So this is poly-resistant. So we have got RR TB means rifampicin resistant, and ISR, and these two are important for us right now here. Then another important term is MDR, multi-drug resistant here. As everyone knows, MDR-TB is a TB patient whose biological specimen is resistant to both isoniazid and rifampicin, with or without resistant to other first-line ATT drugs, for example, pyrazinamide or ethambutol. And this usually MDR-TB may also have additional resistance to any or all quinolones, for example, levofloxacin in all and all moxifloxacin like that. Okay, so or any other TB drugs. So MDR-TB is basically resistant to isoniazid and rifampicin, but may have also resistant to other proquinolones and other drugs also. Now, another term which may not be used very commonly also, there is pre-extensively drug-resistant TB, so pre-XDR-TB. So, this is defined as a TB caused by the Mycobacterium tuberculosis strain that fulfill the definition of MDR or rifampicin-resistant TB, but is also resistant to any proquinolones. Okay, here. Then another is XDR, extensively drug-resistant TB here. TB, in this case, TB caused by Mycobacterium tuberculosis here, and that fulfill the definition of MDR or rifampicin-resistant TB, and is also resistant to any quinolones like levofloxacin or moxifloxacin, and at least one additional group A. For example, bedaquiline or linezolid in the drug-resistant group. So extensively drug-resistant or XDR-TB is MDR-TB, rifampicin-resistant TB, and resistant to quinolones, and also with some newer drugs. For example, again here again we can consider bedaquiline and linezolid, which are given in the case of drug-resistant TB. We have got a second line ATTB drugs. So names are like this here. It's divided into group A, B, and C. In group A, we have got levofloxacin or moxifloxacin. So it's a fluoroquinolones. Then most important member in this group is beta-aquilone. And then again is linezolid here. In the group B, consists of clofazimine, which is used in leprosy also, then cycloserine and tiriginidine. Okay. In the group C, here ethambutol again, it was the first line also, but and delaminate is there, pyrazinamide again, then imipenem and cilastin and meropenem, imicacin, azithromycin. These are group C. Group C. So we have got group A, group B, and group C drugs here. Let's have some side effects of the newer second line drugs. For levofloxacin, seizure and headache is the main side effect. Okay, and then for moxifloxacin also again mostly on the cardiac defect. QTC prolongation is there. QTC prolongation is there here with moxifloxacin, especially with the higher dose. Then what about the beta-aquilone? Again, it may produce gastritis. And hepatotoxicity here again in ECG changes in the form of prolonged QTC, and then of course electrolyte imbalance and also myopathy. And linezolid, another popular molecule in the second line, is just like isoniazid, it may produce peripheral neuropathy and also optic neuritis is in the case of ethambutol, and the bone marrow depression here. Clofazimine again, color is very red, so reddish discoloration of not only urine but also skin, and again ECG changes in the form of prolonged QTC and photosensitivity. Cycloserine, really it may produce psychiatric manifestation in form of insomnia and then depression, and very seriously may also psychotic form also may be there. Ethambutol, as we have discussed earlier, main effect is ocular toxicity, and then delaminide is again ECG changes, QT prolongation, and pyrazinamide we have discussed in the first line, joint pain and severe hepatotoxicity may be there. Imipenem and cilastatin here combination may produce diarrhea, nausea, vomiting. Then for meropenem, of course, fever, chill, lightheadedness, then dizziness, sweating, and then of course tachypnea may be there, skin rash may be there. Imicacin, the immunoglycoside, main effect is nephrotoxicity, and also and the ear ototoxicity there. So patient may complain of ringing in the ear and even the reduced hearing also. Azithromycin, just like imicacin, same thing is imicacin, nephrotoxicity and ototoxicity. Ethoniamide, gastritis and hypothyroidism may also be there. And then again, proteinuramide also just like ethoniamide, gastritis and hypothyroidism pieces may be there. This is a very little busy slide regarding the algorithm of programmatic management of drug-resistant TB as per the this 2021 guideline here. We'll just have a look here. All TB patients and representative of TB, or of course here, then or non-responders. So they should undergo nucleic acid amplification test here. Then of course they should be first tested with then here nucleic acid amplification test, and then they should be tested with culture and drug sensitivity test here. We'll just read on the right side here. Then we find that rifampicin resistance is not detected on the drug sensitivity test. Then of course in such a case, then we have to give drug sensitive TB regimen should be given, just like in case of first line. And then we can do first line probe assay, and this is for isoniazid resistance. If rifampicin resistance is detected, of course, and then of course we go for drug resistant TB regimen. And if isoniazid resistance is detected, in that case we have to stop drug sensitive TB regimen here, and then of course we have to give this thing MDR TB regimen here. Now we'll reach on this side again. Rifampicin resistance is detected. In that case, what we should do is we have got some other tests. One is first line probe assay, and then second line probe assay again, and then liquid culture drug sensitivity test again, and then these tests are done. Then our regimen will be pyrazidamide, bedaquiline, clofexamine, moxifloxacin, linezolid, and dilaminamide. All these drugs are given here. After completion of this thing PTE, then of course we can check in the next high then with the availability of culture and drug sensitivity tests, if the live assay is results available or not. If done, then of course resistant to isoniazid is detected. In such a case, of course we have to give drug resistant MDR-TB. And if this thing on this testing, we find that no additional resistance detected, and then isoniazid resistance is detected. In this case, total course of oral bedaquiline is given containing MDR region. Of course, this slide, of course, there is explanation is there, so I'll just skip this one. Type of this thing, drug resistant TB on one column, and what is the regimen, standard regimen on the other side. Okay, here. So here we have got mono-resistant or poly-resistant drug resistant TB on one side. In such a case, here the regimen is the other resistant TB regimen is given here for 6 months, containing levofloxacin, rifampicin, and isoniazid and pyrazidamide. Then, if MDR-TB is there, or including rifampicin resistant TB is there, then we go for shorter oral bedaquiline containing MDR regimen here. This is 4 to 6 months of bedaquiline, 6 months, levofloxacin, clofexamine, pyrazidamide, ethambutol. This means a high dose isoniazid. This is then ethionamide. Then continuation phase is 4-5 months of levofloxacin, clofexamine, pyrazidamide, and ethambutol. Here we have omitted bedaquiline here. Then again, if we opt for shorter injectable containing regimen, here again 6 months of moxifloxacin, here kanamycin oblique amikacin is the injection here, ethionamide, clofexamine, then pyrazidamide, and then high dose of isoniazid, ethambutol of 4 to 6 months of intensive phase, and then continuation phase is 5 months of moxifloxacin, clofexamine, pyrazidamide, ethambutol. Then in XDR, we have to use a longer course of regimen. So the duration is longer here, 18 to 20 months of duration here. Again, here bedaquiline is there given for 6 months or even longer. Also contains levofloxacin, linezolid, and clofexamine, and cyclocin. If the rifampicin resistance is there, then what we have done is these are sensitivity tests. These are line probe, first line probe assay, second line probe assay, and then of course here liquid culture drug sensitivity test. Here we have done rifampicin as well as isoniazid and the other drugs here, and the regimen given here is again Z, pyrazidamide, bedaquiline, clofazimine, and moxifloxacin, linezolid, and dilanminide is here. Then after completing completing is the pre-treatment evaluation here. Here in this case, after completing pre-treatment evaluation and checking on the NICSI with the availability of line probe assay here, if these things are results are available, then of course we have found that resistance, rifampicin resistance, isoniazid resistance is detected. In that case, again, we have to give longer duration of MDR. And again, the explanation again of the SAR. Okay, no resistance was detected, and ICE resistance was detected. Again, shorter oral bedaquiline containing MDR regimen is given. We have to monitor we have to monitor this thing, TB patients clinically as well as of course laboratory wise also in form of sputum microscopy and sputum culture also. This may be done by the this thing nascent tuberculosis elimination program of officials or district TB or DTC staff here. And to determine the outcome of drug-resistant TB treatment in accordance with the nascent tuberculosis elimination program guidelines are either cure, treatment completed, or failure, or not evaluated, or regimen change, loss of follow-up, or maybe died. Now, or died. This one. So, in short, this drug-resistant tuberculosis, of course, we are not actually giving MDR TB in our ERD center, but we have to coordinate with this thing, NTEP center or district TB center, but ERD distinct officials, so we should be aware of the side effects and molecules given and the duration also given, and because we are giving ART distinct simultaneously. Now, ART for HIV co-infected patients on bedaquiline or dilemidamide. So, a few words are important. So, DTC-based regimen should be the ART regimen of choice in case of patients getting bedaquiline or dilemidamide. If the patient is already on NRTI and DTC regimen, the same has to be continued. If the patient is on NNRTI or PI-based ART regimen, then of course, this PI should be substituted with this thing DTC-based ART regimen. Then PI-based second line or third line need coordination between SACEF and should be linked with the drug-resistant TB center also. Then with PI-based ART, then intensive monitoring is again required because of the possible side effects. But there's no dose assessments are needed when dilamidamide is used with tenofovir, efavirenz, or this thing lopinavir, ritonavir. Then if efavirenz is used, then a dose adjustment may not be required. Now, the next subtopic is management of child living with HIV infected with tuberculosis. Here, may have this HIV infected children may have an increasing show of the primary progressive TB or extrapulmonary tuberculosis or multi-drug resistant tuberculosis also, or high case fatality. So just like in the adult also, but in children, fatality is again also increased. And the symptoms of TB on S we have discussed in the 4S group here. In the pulmonary one is fever, cough, failure to thrive, weight loss, or failure to loss of weight more than 50%, 5% of the body weight is compared to the highest weight recorded in the last 3 months, or weight gain or no weight gain in the last 3 months. And then most important thing is history of contact with the TB case. In the form of active TB in the last 2 months. So these are very important clinical features of TB symptoms or history in case of children. Then for about extrapulmonary TB, we have got lymph node enlargement here, lymph node enlargement. Then patient may have headache or confusion because the patient may be having TBM. Then the backache, joint pain, or spinal deformity because of bone TB, chest pain, tightness in the chest, respiratory distress because of the involvement of pleura, pleural effusion or pericardial effusion. Then abdominal pain, swelling, discomfort, and respiratory distress, maybe because of the abdominal involvement in the form of mesenteric limb methanitis or ascites and or history of TB cases. So these are the clinical parts. Now, again, diagnostic algorithm is here. This year, a little simpler. Here we have got patient has undergone a suspected case of TB. In such case, patient has got undergone 4S screening in the ERD center. Then 4S positive is there. Then of course, clinical evaluation. We fast take the patient to the medical officer here. Then if we find that cause for cough other than TB is found, then of course we should treat the fever or cough for the child other than TB here. Then of course we have got two things may be possible here. Either patient has got pulmonary tuberculosis or extra pulmonary tuberculosis. If it's extra pulmonary tuberculosis presented, then of course we have to send the sample specimen for example lymph node specimen or gastric lavage like that. So smear culture or nucleic acid amplification test should be done, and then of course cytology or histopathology examination should be done. X-ray and relevant imaging should be done. And on the other side, suppose if the patient has got presumptive TB, this thing tuberculosis, in that case again we should subject the sputum to nucleic acid amplification test, and then if it's confirmed, then of course is a microbiologically confirmed TB case, TB case, and then if the amplification test or CBNet test is negative, but X-ray is positive, again in this case it's clinically diagnosed case of TB, so we have to start ATD treatment here. Then X-ray and both X-ray and the nucleic acid amplification test is negative. In that case, it may not be tuberculosis. So we can only can follow up only here. Then here. On the other side, extrapulmonary tuberculosis, we have found the evidence that, and then in that case, for example, any one of the more invasive sensitive of tuberculosis, for example, X-ray or FNAC or histopathology, then of course this is a case of extrapulmonary tuberculosis. ATT for drug sensitive TB in child here the drug is again the medicines are isoniazid, rifampicin, ethambutol, pyrazinamide. First line drugs are here. The dose here is for isoniazid 10 milligram per kg. For adult is less than this one. Here 5 to 15, it should be 15, 5 to 15, so not 5 to 7 is wrong, I think. 5 to 15 milligram per kg weight. The maximum dose is 300 milligram, and the rifampicin is again 15 milligram per kg weight, okay, 10 to 20 milligram, and then of course the ceiling is 600 again. Ethambutol again 20 milligram, again 1500 milligram. Pyrazinamide again 35 milligram per kg weight. We used to remember formula here 10, 15, 20, 35, like that. 10, 15, 20, and 35 per milligram per kg weight. So, and the other side here, this is the ceiling, means maximum dose permissible. Here. The daily dose depends on the ATT, depends on the weight band of the patient here. Again, maybe difficult to remember this thing, what do you call it, weight band. So we have to, we usually put a print out of this one kg body weight on our table, and the number of pills here. For children and for adults, and the composition is the same, but the dosing, means the strength is different. For adult, this one was 75 milligram of isoniazid was here, but in this case, 50 milligram of isoniazid is here. For rifampicin for adult, it was 150, but for children is half of the 75 milligram. And pyrazinamide was 400 here, 150 only. And ethambutol 100 milligram. And this is for intensive phase of 2 months and 4 months of continuation phase, the same as in case of adult. But here, depending on the weight band, how many tablets should be given here? We can remember all those things here, but the last 2 lines here, for the weight band of 25 to 30, 29 kg body weight, we give 3 tablets of ISRZ here, and the 1 dose of adult. 1A means adult dose. Adult containing adult 1 tablet contains 175 milligram of isoniazid, 150 milligram of rifampicin, and 40 milligram of pyrazinamide, like that. So 1A means adult tablet. So similarly for 30 to 39 is 2 tablets plus 2 adult dose, 2 adult tablets. So this is the chart we usually print out and give paste on our table. Uh, for children, weight less than 20 kg, or if the age is more than less than 6 years, then what is the age regime? So in such a case, age less than 6 years and weight less than 20 kg. So we have got abacavir, lamivudine, twice daily dose as per the weight band, and then opinavir, ritonavir, super boosting with additional ritonavir, twice daily as per weight. This one is there. But for child weighing between 20 to 30 kg body weight, the age is more, means 6 to 10 years. 10 years here. In such a case here, we give abacavir, lamivudine is in the first case, but here instead of PI, we give dolutegravir. Here 50 milligram twice daily. And for a child, more than 30 kg body weight and age more than 10 years of age here, then again we change. Here, tenofovir, lamivudine, and means TLD. Tenofovir is given, lamivudine is given, and dolutegravir is given once daily with an additional dose of dolutegravir. 50 milligram after 2 hours is in case of adult, because we are giving HRZE. As in the adult, dolutegravir dose will be given twice daily for 2 weeks after stopping rifampicin containing ATD again. And super boosting of lopinavir with ritonavir to be continued for 2 weeks after stopping rifampicin containing ATD drugs. Also, any infant or child initiated on any regimen must be based on body weight. Okay, so for body weight, of course, we have discussed in the previous slide. Again, here we have got another algorithm here. This is for MDR-TB for among the children. So child having TB, of course, and then of course for the specimen we have to find out whether drug susceptibility test is available or not. Is not known. That in such a case, whether is the sample is sensitive to the drugs or not, so we have to do by drug susceptibility test. So here, and then of course, if it is confirmed that drug susceptibility test is there, of course susceptible, all the drugs are susceptible, then in the case treat the patient is a drug susceptible TB case here. On one side, drug resistant TB is there and is found in such a case, and then we have to treat drug resistant TB here. But we don't know the result of the sensitivity test in such a case. Then what should we do? Well, so here history of contact with the TB patient is important. Here TB patient, yes, yes or no. Yes, there's history of contact with TB patient. Yes or no. Source is the source of the contact, means the patient, original patient is TB with drug sensitivity. In such a case, probably the patient is having, the baby or the child is having then probable drug sensitive TB. So treat in the line of drug sensitive TB here. But we should again send the sample for sensitivity test here. Then again, contact with TB again. Yes, is the source is drug resistant TB. In such a case, and then we can presume that the child is infected with the drug resistant TB. So again, we have to do drug sensitivity test, and accordingly we have to proceed here again. Now, another possibility is here, the sensitivity test of the original original patient is not known. In such a case, then we can presume that we have to treat the child as a drug resistant TB, presumed TB. Again, of course, we have to do all the tests again and proceed accordingly. There are some criteria, whether criteria for diagnosis of probable MDR-TB in children. So we have to include children with signs and symptoms of active TB, in whom addition the following risk factors are there: close contact with a known case of MDR-TB, This is very important one. Close contact with a person who died while on TB treatment. So another possibility is there. Close contact with a person who have failed on TB treatment, or there's no response or failure on first line regimen. Then of course previous treatment with second line medication. So these are the points or indications that we have to include the child in the category of probable MDR-TB. Regimen and what are the regimen for MDR-TB in children? So a shorter oral bedaquiline containing MDR-TB regimen of 9 to 12 months duration is recommended in case of children who are eligible with confirmed MDR-TB and who have been exposed to treatment with drug-resistant TB earlier in this regimen for more than 1 month, or in whom resistance to fluoroquinolone has not been documented in such a case. So bedaquiline containing MDR-TB for this thing 9 to 11 months is there. But another option is shorter oral bedaquiline containing MDR-TB will be introduced in the country in a phase-wide manner, but at present this is not available in all places here. Then until complete geographical coverage and then of course transition is complete, in that case we have to continue the user. Then we can use injectable containing MDR-TB regime also here also. And then of course this shorter course is 4 to 6 months of bedaquiline, 6 months, and then levofloxacin, clofazimine, paracetamide, ethambutol, high dose of isoniazid instead of 7 milligram per kg, where 15 milligram per kg may be used. Then ethoniamide. Then continuation phase of 5 months of levofloxacin, clofazimine, paracetamide, and ethambutol. So this is the regimen for MDR-TB in the children with HIV infection. Certain cases here, certain scenario are there here. Patient, we have got certain cases, TB patient treatment in a condition where patient is already on protease inhibitor based ART. So what should we do? Rifampicin suppresses, as we all know, biology of this thing, PIs in atazanavir, ritonavir, olopinavir, ritonavir, darunavir, ritonavir, whatever. However, rifampicin has an effective ATTB drug, and so does not inhibit the effectiveness of the drugs. So rifampicin is the molecule which has to be changed to rifampicin in case of PI containing ART center. So, but rifampicin is not available in the fixed drug combination supplied to us here. So, hence it should be provided as a loose drug, and the entire duration of the TB treatment, so rifampicin should be used in case in place of rifampicin here. Then ATD drug initiation should be done as soon as TB is diagnosed, even in patients on PI-based ART. If substitution of rifampicin with rifampicin cannot be done immediately because of many reasons, and then one should not reconsider super boosting of PI and 1:1 ratio is in case of children, but not in adult. In children, but with higher ritonavir dose in adults, toxicity will be very high, and hence these are not recommended. So rifampicin should be ensured very quickly. Then whenever available, rifampicin should be replaced with rifampicin 150 milligram. Then if rifampicin is continued for longer duration, this will make the boosted PI-based regimen ineffective and will hasten the emergence of drug-resistant mutants and eventually ART failure. So our concern is replace rifampicin as fast as possible with rifampicin. If rifampicin is not available, of course, we have to continue PI for some time, but continuing rifampicin in PI-based regimen will result into the single resistant drugs, HIV mutants very fast. Some scenarios are again TB treatment in children living with HIV and protease inhibitor PIBS ERT. So super boosting of lopinavir with lopinavir is recommended in case of children, not in adult, in 1:1 ratio. If the age is more than 6 years of age and weight is 20 kg, replace this thing protease inhibitor with dolutegravir given twice daily that we have seen in the algorithm again here. Then again, another scenario is here: a pregnant woman or a patient is nursing mother. Then in such a case, all primary ATD drugs are safe. For example, HRZE are safe during pregnancy and the lactation, so it should be continued. But among second line ATD drugs, second line ATD drugs, injectable one, amikacin, estromycin, of course, these are contraindicated for pregnancy because of their effect on the air canal nerve in the fetus, of course, and then use of again propranolones during pregnancy, for example, levofloxacin and moxifloxacin can affect the cartilage of developing fetus, so it should be avoided. Ethionamide is contraindicated during the first 32 weeks of pregnancy because of the teratogenic effect. Again, bedaquiline and delamide, of course, best avoided during pregnancy till there is more evidence, because we don't have much evidence of their safety. And then shorter quinolones, shorter this thing, bedaquiline containing MDR-TB cannot be invested during pregnancy. Of course, this is another issue here. Among ART, dolutegravir and rifampicin containing regimens are safe during pregnancy. However, because of the possibility of neurologic distinct defect in the baby, the mother has to be informed and has to be counseled, and the patient may or may not of dolutegravir. So if dolutegravir is not used, then rifampicin is the option here. Then another scenario is renal impairment. For renal impairment patient, what is the dose of ATT, in that case ART, or is it already there? So ATT, we have to calculate creatinine clearance again. If the creatinine clearance is more or less than 30, less than 30, or patients are receiving hemodialysis, then for isoniazid, no dose adjustment is required. For rifampicin, also no dose adjustment is required. For pyrazinamide and ethambutol, and these two drugs, of course, dose is same dose as before, but it should be given only thrice a week, So 25 milligram, 35 milligram per kg weight, given thrice a week, not daily. Again, similarly, ethambutol also not daily, like that. And for tuberculosis associated IRIS here may occur, of course, TB IRIS may occur up to 1/3 of the patients who have been diagnosed with TB and have been started on ART. So again, we have to be very vigilant here. Typically, this immune reconstitution occurs within 3 months of the initiation of ART. So again, we have to be very vigilant and we have to counsel patients again. The first 3 months is very important. Commonly, these patients present with appearance of new or worsening or existing TB signs and symptoms, and then, for example, maybe extrapulmonary or pulmonary. These symptoms are like the paradoxical reactions seen in immunocompetent patients on ATT, but may occur frequently with HIV-infected patients, of course. Then at times, serious reactions such as meningeal TB, respiratory distress, and then massive lymphadenopathy may cause tracheal compression and respiratory distress. Such cases also should require the use of anti-inflammatory drugs, including steroids. Of course, steroids should be monitored and it should be tapered very rapidly. So, and the general principles of the treatment and prevention of TB in people living HIV at the ART center are: the intensify case finding IFCs using 4 symptom complex is very important. Then, of course, TB preventive therapy in case of in the form of ITP. Those who are eligible and eligible ITP should be started very fast. And then, airborne infection control. And regarding IPT, there may be some questions whether giving only one molecule is effective, or whether the chances of development of drug resistance is there or not while giving isoniazid alone. So the explanation is isoniazid is one of the most effective bactericidal ATD drugs that protect against progression of latent TB infection to active TB disease. And that also prevents TB infection post-exposure to an open case of TB. And thirdly, the IPT augments the effect of ART on reducing the incidence of TB again here. And IPT does not mean isoniazid preventive therapy does not promote isoniazid resistance when used to treat latent TB in a infection. Airborne infection control, last few slides earlier, so not very long. The presence of immunocompromised patients in healthcare and congregate settings lacking effective infection control measures create a favorable environment for TB transmission. For example, windows closed or not proper window or like that. So ART center is one of the high risk settings for TB transmission. So this is very important for everybody to keep in mind. So effective implementation of airborne infection controls involves the following one: managerial measures from all everybody involved here, administrative controls, for example, from the authority of the hospital side, like then environmental control, personal respiratory protection in the form of using even masks. Not only it prevents the transmission of COVID, but also transmission of TB here. So managerial measures from all staff concerned, administrative control from the hospital side, environmental control, and personal respiratory protection from patient itself and from the staff also. So with this, we have gone through some of the typical areas, for example, in the drug-resistant TB, MDR TB also, but in all, TB and HIV co-infection is very common, and this is a bidirectional condition here, one increasing the other one. So TB infection is one important commonness OI for all of us to treat and to prevent it. And thank you very much for your patient hearing again.
Thank you so much, sir. Sorry, it was a lengthy session. Thank you to all the participants also. Any questions from the participants? So we have one in the chat box. What is the difference between first line LPA and second line LPA?
First line line probe assay. This is test usually done for depends on the laboratory method also. The first line and the second line line probe assay usually done for the detection of resistance to isoniazid. The methods are different.
Any more questions from the participants? Kiran sir, we can meantime run the feedback form, please. So there's a question: when DS-TB patient will take ATT with food or without food? Will a DS-TB patient?
Madam? Please, can you please repeat? I cannot see the chat box.
Yeah,
so,
right. A DS-TB patient will take ATT with food or without food?
Usually, ATT drugs are given in the empty stomach, but many patients they don't tolerate. For example, rifampicin is given in the empty stomach and the better absorption. But for example, paracetamol, ethambutol, they may have some gastric irritation also, even rifampicin also. So in such a case, of course, after food, for example, after breakfast and all.
Thank you, sir. Any more questions? Kiran sir, please run the feedback form. The feedback poll is visible on the screens. We know it, we are short of time, but please in 2 minutes, if you can quickly answer the questions. Participants are requested to please answer all the 4 questions. Kiran sir, is the poll being answered?
Yes.
Yes. Requesting all the participants to please answer the feedback poll. So we can end the feedback poll now. Thank you, sir, once again for facilitating this session.
Thank you, Madam Sweta. Thank you very much.
Thank you, sir. Thank you to all the participants for patient listening. We'll conclude the session now.
Okay, thank you very much again.
Thank you, sir.